Hi, and welcome back to the Pro PA podcast. I'm Angie Urbina, your host for this cardiovascular series. Today we're talking about a silent but possibly deadly vascular condition, abdominal aortic aneurysm, or a AAA. While often asymptomatic, when it ruptures, it carries a high mortality rate. In this episode, we'll cover the pathophysiology, who is at risk, clinical presentation, diagnosis, management, prevention, and some clinical pearls to help you in both clinical practice and for your PANCE or PANRE prep. Let's dive in. Starting off with some basic pathophysiology, an abdominal aortic aneurysm is a localized dilation of the abdominal aorta, typically defined as an aortic diameter of greater than or equal to 3 centimeters in an adult. It results from progressive weakening of the arterial wall due to a multifactorial systemic process that includes chronic inflammation, atherosclerosis, and lower elastin and collagen content. Over time, the aneurysm expands, and if left untreated, it may rupture, leading to catastrophic internal bleeding. Most AAAs occur below the renal arteries, but they can extend to involve the iliac arteries as well. Now, who do AAAs affect? An abdominal aortic aneurysm is most common in older men over the age of 65, particularly those with a history of smoking, which is the strongest modifiable risk factor. Other risk factors include hypertension, atherosclerosis, a family history of a AAA, connective tissue disorders such as Marfan's and Ehlers-Danlos syndromes, and history of other large artery aneurysms. Now, one last thing I'd like to mention here is that the risk is 4 to 6 times higher in men than in women. Moving on to the clinical presentation, what is worrisome about AAAs is that most are asymptomatic and often discovered incidentally on imaging done for other reasons. However, when symptoms do occur, they can include abdominal, back, or flank pain. This can be due to compression of surrounding structures. They might also present with a pulsatile abdominal mass, and although not always present, an abdominal bruit may be auscultated. Now, in the case of a ruptured abdominal aortic aneurysm, the classic presentation is of severe abdominal or back pain, hypotension, and a pulsatile abdominal mass. This is something you don't want to miss. Moving on to the diagnosis, if a AAA is suspected, the best diagnostic test depends on symptomatology and clinical stability. For asymptomatic patients, abdominal ultrasound is the initial test of choice. It's fast, non-invasive, and has high sensitivity. It is also the diagnostic test of choice for screening, specifically men aged 65 to 75 who have ever smoked, and may be considered for those with a family history of a AAA. For symptomatic but stable patients, CT angiography is preferred as it provides detailed anatomical information when planning operative repair. And for unstable patients where rupture is suspected, these should be taken emergently to the operating room for immediate control of hemorrhage, resuscitation, and repair of the aneurysm. Now, let's move on to the management. The management depends on the size of the aneurysm and symptoms of the patient. For most patients with asymptomatic AAAs, conservative management is recommended. In general, elective repair is indicated for a AAA 5.5 centimeters or larger in men or 5 centimeters in women. Patients should have periodic imaging every 6 to 12 months. This is usually an ultrasound, but when the aneurysm nears the treatment threshold of 5.5 centimeters, then a CAT scan should be done because it provides a more reliable assessment of aneurysm diameter as well as anatomical information needed for surgical repair. Now, there are situations for which elective repair of a AAA less than 5.5 centimeters may also be appropriate. These may include rapidly expanding AAAs, growing greater than 0.5 centimeters in 6 months, or greater than 1 centimeter per year, Also, if a patient is experiencing symptoms of pain or tenderness, which may indicate impending rupture. In these cases, urgent repair would be required regardless of the aneurysm's diameter. And options for repair include open surgery or endovascular aneurysm repair. Regarding prevention, this starts with controlling modifiable risk factors. Blood pressure control, smoking cessation has the biggest impact, statin and aspirin for atherosclerosis management, and routine ultrasound screening in high-risk individuals. Here are some clinical pearls. Number 1, AAA is often asymptomatic and found incidentally. Number 2, smoking is the biggest modifiable risk factor. Strongly encourage cessation. Number 3, AAA rupture may present as severe abdominal or back pain, hypotension, and a pulsatile mass. Number 4, ultrasound is the best initial diagnostic test for stable patients. And number 5, ruptured AAA is a surgical emergency. Time is of the essence. All right, let's practice some clinical questions. Question 1. A 70-year-old man with a 45-pack year smoking history presents to establish care. He is asymptomatic. Which of the following is the most appropriate next step? Is it A, order a CT angiogram of the abdomen? B, schedule an abdominal ultrasound? C, start the patient on a statin and aspirin? Or D, refer to vascular surgery for immediate repair? I'll give you a couple of seconds. If you chose B, schedule an abdominal ultrasound, you are correct. The USPSTF recommends one-time screening with abdominal ultrasound in men aged 65 to 75 who have ever smoked to detect asymptomatic AAAs. CT angiography is not necessary for screening unless a AAA is detected and requires further evaluation. Question 2. A 67-year-old man presents with sudden onset severe back pain and syncope. His blood pressure is 80/50 millimeters of mercury. Heart rate is 120 beats per minute. And he has a pulsatile abdominal mass on exam. Which of the following is the most appropriate next step? Is it A, start IV labetalol and admit for observation? B, obtain an urgent CT angiogram? C, prepare for immediate surgery? Or D, administer IV antibiotics and monitor in the ICU? If you chose C, prepare for immediate surgery, you are correct. This patient has classic signs of a ruptured AAA, hypotension, back pain, and a pulsatile mass. Patient should be taken emergently to the operating room for immediate control of hemorrhage, resuscitation, and repair of the aneurysm. CT angiography is only for stable patients. In unstable patients, don't delay intervention. Great job! That wraps up our discussion on abdominal aortic aneurysms. Early detection and risk factor management are key to preventing catastrophic outcomes. Whether you're screening high-risk patients in primary care or recognizing the red flags of rupture in emergent settings, understanding abdominal aortic aneurysms can make all the difference. Be sure to reinforce smoking cessation, blood pressure control, and timely imaging to catch these before they become emergencies. If you found this episode helpful, don't forget to subscribe and share with your fellow PAs. And as always, this is the Pro PA Podcast, where future pros in medicine are made. See you next time.